Hello, I'm Tom DiBerardino from San Antonio, Texas. Today we're going to go over use of the Arthrex iBalance HTO system to perform an opening wedge high tibial osteotomy. The procedure starts on the left knee. The incision is small, it's linear, it's about 4 centimeters at maximum in length. It can start commonly with an arthroscopy, so I'll tend to use vertical portals. Like many of our techniques, like an all-inside ACL, we always tell the surgeon it's important to hug the patellar tendon because a lot of the guides mandate being hugged up against the patellar tendon to get the instruments into the notch. In this case, we want to be hugged up against the patellar tendon because we're going to cut down, continue from our portal down several centimeters, and we're heading toward the pes anserine, which is about 2 finger breadths below the joint line. So that's always, interestingly enough, where the cut from medial to lateral occurs. It's right at the top of the pes. That's always a good landmark as we get into the knee. So here we have our landing spot for our hinge pin. It's always down 1.5 centimeters from the plateau and in from the lateral wall of the tibia about 1 centimeter. So I've marked here with a surgical marker this very palpable landing zone. We can feel the edge of the patella tendon. That's where we always make our incision. It's a vertical incision about 1 centimeter in length, and within that centimeter will be our perfect point to be safely in from the cortex 1 centimeter and again down from the plateau 1.5 centimeters. So the ratio is 1.5 to 1, and that's important for 2 reasons. It's the anatomic location that the technique remands to get a good cut. It also, from a load standpoint, makes it so that if you're going to get breakout, you're going to break out preferentially laterally at the robust tissue around the tib-fib joint, and you're still going to have a nice periosteal hinge. But more importantly, you should be far less likely to ever break out into the plateau, which would create a lateral plateau fracture, which would be manageable, and we can talk about that later. But the idea is to put it down in this position, and I often now, having done this for over a decade, will make this incision as the first actual incision, because I know that's a fixed point, and that's where everything starts and ends from. It's the hinge pin of it all. So we know our osteotomy is going to be right here over the palpable pes and aim at about that degree or slope. It's basically a flat cut that becomes an open triangle based on the degree of correction. So here we have a metal ruler, and it's got different arrays of dots, too small, too large, too small, so we can tell without looking at the measurements, which we can't see the numbers on the image, but we can take a measurement in front of the tibia and then in back of the tibia, and using fluoroscopy intraoperatively, we can take the average of the front measurement and the back measurement and get what's deemed as the average measurement for this tibia. And likewise, that should mirror what we did preoperatively in the clinic. So it'll tell us whether this knee or this tibia is a small, medium, large, or extra large width. Our correction's already dialed in on our preoperative imaging. So we use a 10 blade. We come down. This could have been our previous portal right here. So we just extend it down to about the tibial tubercle, because that's concurrent with the pes. And we're going to retract the pes. We're going to incise just above the pes once I get in here. But the first order of business upon getting into the knee is to use our scissors to dissect under the patella tendon, because this is a patella tendon-based approach. We want to own the patella tendon and protect it. But everything's kind of based off the patella tendon, as we mentioned with the hinge pin. So I'll slip my finger in behind the knee. Even in resting flexion, there's usually enough play to get an index finger behind it, and I sweep, and I kind of can feel that apex where the highest point of the insertion medially of the patella tendon is. So that combined with our hinge pin is 2 points, and that really dictates the slope of the cut. Going backwards, we extrapolate over to the pes, and now we have 3 dots. Pes, medial patella tendon, hinge pin, and that creates a line, and it's always about this inclination. So we have to safely dissect behind the patella tendon. If they've had a prior ACL, we have to take into account the fact that the patella tendon could be scarred down. So I'm making sure I'm down with a curved blunt instruments. That's the lowest part. And it should be below where you think the hinge pin will be, because that's going to create this slope. And then working backwards, we're going to get the pes in just a second. So the next order of business is to cut right up to the joint line, but you don't want to enter the joint line. There's thick tissue, retinacular tissue, that we're going to peel off in an inverted L. So this is the vertical arm of the L, and this is the horizontal arm of the L, and it's going to retract right over there. So here is the medial border of our patella tendon. We're going to cut across, and we're going to make an L just of this retinacular tissue. We can use a cautery or just scissors to dissect this off. So we want to get down to the tibia here. We don't want to cut into the joint here. This periarticular fat is important. We can feel the top of the slope of the tibia right here, the lip of the front edge. So we're going to eventually break down to bone right there, but we'll keep the joint intact. So I'm going to incise the sartorial fascia obliquely so we can protect our hamstrings. That's like the belt line of this whole operation. And the MCL in this medial retinacular tissue will end up being the shirt tail. We're going to tuck in. So we break into the pes. And we're above this, the MCL. Right down here is the superficial MCL. So we're going to protect this pes and develop this tissue plane here a little bit. The sartorial fascia gets incised. But there's our MCL right here, broadly across there, coming from superior to inferior and anterior. So now we've got the pes in my pickup. We're going to retract with the Army-Navy, the long end. That's going to give us depth into this wound. And I sweep with my finger, and you can feel the tendons proximally and the insertion site down here. So the hamstrings right here below my scissors and below the sartorial fascia have a broad insertion all the way over to the tibial tubercle to the right. So we can safely release either with bovie or with scissors this tissue to get a little more excursion and really overprotect our hamstring, because we don't want to take the hamstring. So our subperiosteal dissection, starting way back up here, is going to take us down under the MCL. We're going to release that off all the way down into the depths of the wound down here, another 1/2 inch or 2 centimeters. Then we'll take a cob and on bone, get under the MCL. You can feel it on bone. Makes a scraping sound. We're going to go south or distal, and we're just going to push off the MCL, the superficial MCL. And you can see I'm starting to see bone in there. There's the edge of the MCL right on the edge of the cob. So I'm taking that distally and I'm pushing it off the tibia. Sometimes if I bring the knee up in a little bit out of pure flexion to take the tension off, you can hear it just come off, and you'll feel it. Eventually you can get a finger under there and you can feel if there's still fibers left. So I can feel there's still tension. So I need to release a little bit more. And you can go up to the deep MCL, which is well below the osteotomy, but gives you good safety. So the superficial MCL is now loose off the tibia. It was snug up against it, but now I've got this big working space, and this is the back corner of the tibia, right where the cob is. It's starting to turn the corner. We'll often use a bovie to make a line here, just to remind everyone that's the target, and we can make our little cut back here with a cautery. I'm going to use the cob here. And we want to stay on bone. In a resting flexed knee, that's important because that is added value for protection of the important neurovascular structures behind the knee, and especially the popliteal artery. So we don't plunge. I've got my hand up against the tibia, and it's the guide, and then my left hand is gently sweeping proximally and distally, just making a little fighting position on bone back here. So that's the regular cob. Now I take the curved cob out of the set, which is a nice device. It's got curvature that mimics that back corner of the tibia. So we're going to work around and stay right on bone and go right around the back side of the tibia. And you can feel it. It's very audible and there's good tactile feedback. So I get that in there. And now we just totally walk across. And I'm on the tibia in flexion, or pretty much all flexion. So I know I'm submuscular and I'm on the periosteum of the tibia. And you should feel bone the whole way. And I'll oogie it over or walk it over with a rotation of my wrist until I get over to about where the tib-fib joint is. You can never feel this. Indirectly, you can tell. You can grab the tib-fib joint with your opposite hand and you can feel that you're heading toward it. Or you can get a fluoroscopic view that shows your guide aiming toward the proximal tib-fib joint. But that's the right vector, and it mimics that vector that we work backwards from, the hinge pin, the medial patella tendon, and the posterior medial tibia. So it's in line with our expected osteotomy. The next order of business is to assemble and or receive the assembled biplanar alignment guide. So this device has some key parts to it. It's got the ergonomic handle that's radiolucent, and that just gives you good control as a surgeon and keeps your hand out of the fluoroscopic imaging field. It's got the all-important hinge pin and hinge pin sleeve and the cotter bolt that locks it down. It also has on it the size determination. based on preoperative imaging, we've determined that this knee will require an extra large. And that gets assembled simply by taking the hinge pin sleeve off. It slides on this rail, and this will adjust the size. So by putting the biplanar alignment guide on, I can then place it into the large slot or the medium or the small. And again, we chose extra large on this. So that sliding bar is now locked, and the cotter pin goes on. And I'll place the hinge pin sleeve. So here we have the biplanar alignment guide all pre-assembled. We own the patella tendon, so we put first order of business is the patella tendon guide. Then we sweep in below the MCL with our posterior medial tibial guide, and that's on bone now. So then the other purpose is to look here laterally and see where our hinge pin is going to be. Here's our lateral border of the patella tendon, and here's the lateral tibia. So we're about 1 centimeter in off my index finger where the hinge pin lands on bone, and we're about 1.5 centimeters down from the joint line. So it's exactly where we pre-planned. So we're going to make our incision real quick, down to bone. We're going to spread that with a little mosquito, and then someone's going to push in the hinge pin guide. Good, it's in skin. And now I'm on bone here. I'm on bone here with the tibia. I have the posterior medial skid palpable in the depth of the incision back here, and I can feel with my index finger back here that rotation is right. So I've got rotation control, I've got depth control because I can feel the tibia, and the biplanar alignment guide is parallel with the joint. I'm low down on the patella tendon, and I can check rotation both with the posterior medial tibial outrigger and also the hinge guide. I can tell that that's rotated inward, that's outward, and that looks just right anterior to posterior. So now we'll pin our guide in place and we'll move on quickly. So I usually pin the first one is this right where the extra large sign is right there. We'll pin that into the tibia. So the last thing before we pin this is flat slope. This is a little bit of tibial slope, and you can match the patient slope by feeling along the joint line. And we've matched that slope, and now we're going to pin that in place, and that locks down the slope and the rotation. Good. Now we come in with our second pin, and we often have to retract the skin and the MCL before we put that second pin in right here below the handle. And at this point, every osteotomy looks exactly the same. We can remove our retractors because now it's self-contained, and now we're going to drill front to back with the hinge pin drill through the sleeve. And you should feel both cortices. And it's almost a hard stop at the full length of the drill, and that's just the way the system is set up. So that comes out, and you own that hole because your system's pinned to the tibia. So we take the collet nut off and the sleeve out, and then we put in the hinge pin guide with the flat side toward the cut, and this slot will go into the metal slot. Sometimes a light tap with a mallet, and one hand controls rotation as you just tap it into place. Collet nut goes back on after the guide goes off, and then we're ready to make our barrel cuts, and then finally our osteotomy cut. With that tightened in place, we're now ready to make these two cuts, and again we're going to save the cancellous bone that collects in the grooves of the drill. So then we bring in our big drill to make the two barrel cuts that are the same. They are the center line that take up and will be replaced by the bulk of the PEEK implant. It's a hard stop to bone, and these cancellous fragments can be collected and used as autograft. So now we take this apart really quick. When you drill your first hole, you can tap into place with a mallet this cylinder to kind of lock in that position. But if you think about it, it's already pre-held nicely by the two pins and the hinge pin. It's not going to really move. You can put that in before you drill your second one. So now we've drilled our cuts. We're going to take this apart and take off the drill guide, and we're going to put on our NV shield guide, and then we're ready to make our osteotomy cut. So we're about 3/5 the way through the operation already. So here are the two drill holes, and the osteotomy is going to bisect right through the midline of these two barrel cut holes. So at this point, every cut looks the same on every tibia. So now we put our guide on using the rail system over here immediately on the tibia, and it's got a pre-placed screw will retract this skin so it doesn't get pinched. We'll take a mallet usually here to love tap this in because it's tight. And then we'll use the screwdriver to really compress it down so it's metal on metal. And it goes right in the hole. And you want to look right here to make sure that's flush. So here the NV Shield guide goes in much like the curved cob, except it's longer and broader to cover that whole expanse of the tibia. So we use it as its own retractor, just like an Army Navy, to pull this way. Then we rotate 180. So now we're on the posterior medial corner of the tibia, and we're rolling our wrist, in this case from right to left, along the back of the tibia, in line with the guide system. And then we walk it back, and then we get it into the groove, and then we'll use the pre-placed pin or screw to lock it in to the threaded hole and use the screwdriver to tighten this down. So just like the other parts, you want to make sure this seats fully. And now we've really owned the tibia. You can see the threads coming out on the deep side right here. And you can see you've negated the interface between the shield and the shield guide or the rail system. So that's locked down hard. And now we have that circle of steel around the tibia. So the handle comes off and the saw blade comes up. This just slides off. So now we want to bring the saw, and it's a stiffened blade. So we're going to make sure we go like this to pop up the patella tendon guide and know we've done that first. And I like to do that first. So that's a hard stop against the hinge pin, and you can see the guide is already floating forward. So I've done a good job making that far anterior cut. Following that curvature of the guide, I'm going to do the posterior medial border and roll my wrist with the metal shield over to the hinge pin posterolaterally. And that's a hard stop against the hinge pin back there. So now I'll take the osteotome that's angled, and first I'll just walk it in by hand. Light touch, listen for metal on metal all the way around. And if there's any question, I'll use the mallet in a second to confirm. But here I'm floating that patella tendon retractor forward, so I know I've broached the cortex, and I'm going right to metal right there. One bang here usually finishes that off. And then I'll walk it around with some light taps posteriorly, rolling my wrist with the curvature of the NV Shield until I get over to the posterior medial corner. And again, I'm hearing metal on metal there. So now we can take the entire jig system off. The collet pin with a universal wrench, pin extractor, hinge pin remover comes into play now. It's got a slot to pull everything off. So once I've released that, this comes out in the reverse motion. Rotate your wrist, pull it out. Take off the guide system for the NV Shield. And then everything comes off. So now what we have here is you can see, and it should have a little bit of play. And you can see the micro opening right here at the osteotomy. So I already know we've done a good job with our osteotomes and our saw and our system. So now you have to control this because I've got this hanging over the bed in resting flexion. So the opening jack now comes into play. These two flanges, this goes in the back. It's wider for the wider part of the implant. It's going to mirror the posterior medial cortex. And here, this goes in front of the two barrel cuts. So this now goes in. I'll use the cylinder sleeve to put into the posterior drill hole and use that as my guide. Sometimes I'll use an Army Navy back here to retract, just so I can show you what we're looking at. So that's on the posterior medial corner, and this is going to come down. We're going to do a slight opening under control, and then those two flanges are going to go into the osteotomy site. Sometimes we'll take a mallet and tap this in until it effaces the medial cortex. And we can feel it and see it, that's down on bone and it's snug up against. And if you look here, that mimics where the hinge pin was right here. So that's the opening rotational pivot point, if you will. And now we take this winged threaded screw, and this is actively pushing rail B away from rail A, and it's physically opening the osteotomy. So this is the gauge. There's a small and a medium, and now we're using the large and extra large. So there's a little cutout here that attaches to that little prominent point there, and that's your 0 point. They're marked here with laser marking. So we said we're going to do either a 6 or an 8 on this knee. So we twist it open, And remember, at 6 degrees, we're going to crack that posterolateral cortex. So you open it a couple degrees at a time, because in an older patient, you're getting stress relaxation of that lateral cortex. So we know that if we do it violently, we're going to crack it every time. If we do it slow, in increments of 2 or 3 degrees, give it some rest. Just take a second, take a breather, and then go back at it and slowly ramp up to your desired degree of opening. So these flanges take up physical space. So if I'm going to put an 8-degree opening device, I got to open it 2 more than that. So I got to open it to 10. And right about now, we should hear at 6 degrees of opening a pop in that posterolateral cortex. And now we're going to put in an 8. There it cracks for sure. That's good. So everything's stable now. And either I'm holding the leg or my assistant is, and someone else is reading off the numbers. So we got that right down to 10. So here we have our actual device. It's an 8XL size, and we've got the prominent posterior aspect and the tapered anterior aspect, and you've got your bicortical fastener drill holes below and the cancellous fasteners for above. So we're going to first put, the technique is slide in the backside first, and I have an Army Navy in there just to protect the MCL and the PES and all the soft tissue structures. We lightly put it in with a little bit of finger compression. And then once we're in about 2/3 of the way, I can take this off. It's done its job. And now I'm going to work with a screwdriver to take this spreader bar apart. We're actually applying a little bit of varus, not valgus, a little bit of compression force now, because our device is seated, but it's not fully seated. We're going to take the spreader bars off gently. And you can take them off a piece at a time if you take the wing nut off. We take that off. We take the outer one off first. So I'm holding the device with my thumb, and I'm wiggling out. We can use the handle sometimes. It's more controlled. I've just got my index finger securing the device, and I'm using this ergonomic handle now, and that comes out. And then the second one usually comes out very easily. So now you can see that's the first look. So this lined up very nicely. We've got the posterior medial cortex of the tibia coplanar and linear with the back of the device. So it's a cortical suspending device. And if you think about it, you've really suspended, you have cortical coaptation with the device from the front, from almost the tibial tubercle, all the way around the posterior medial corneal. So it's dissipating the forces nicely. It's flush both on the top and the bottom edge. So the proximal tibia is flush with it, and so is the bottom edge. And then at this point, we hold a little bit of compression load. And now our goal is to put the fasteners in. So we've got the cortical sleeve and a drill that goes bicortical. At this point, you have to decide which bone void filler the surgeon wants to use. We often use Kwikset, and this injection hole is perfect right here, anteriorly between the device and the patella tendon. You have a nice window to put in some bone graft and bone void filler of choice. So these go in. You can check with fluoroscopy, obviously, but they go in between 18 and 24. So I empirically drill in. There's a laser mark, and there's markings on the drill sleeve. You can just go to about 20 to 24, and you can feel that you're not going through the plateau. So you drill 1, and then you drill 2, and then you put in the correct size screw. And this has a Morse taper, so it fits in there nice. And these don't need to be tapped. They're cancellous screws. So these get put in with a screwdriver. And the current screws have a radio opaque marker on them, so you can use them to kind of track your screws radiographically if you so choose. And they have a hard stop and a click, kind of like a gas cap click where it's done. So that's one. And then the second one goes in. So then we use the bicortical distal fasteners are placed. And it has its own special depth gauge that accounts for the fact that you can't see these screws or the screw tip. Feel the second cortex. You can see this nubbin out 2 threads worth outside the cortex. It's got not a laser mark, but a step off, and we're going to read that right in the sleeve window to get our measurement. And now we have our screw length measurement. It can be confirmed by fluoroscopy. Tap comes in. This is a bicortical tap as well. Otherwise, we risk blowing out, or because these are PEEK fasteners, they aren't a cutting, self-tapping screw. So we have to pre-tap all the way out the cortex. This comes out. Screw goes in. You want it flush with the device. and then you'll hear a click right there, and you know you're done. Same thing on the second screw and the final of 4 screws. This one's also bicortical. Put our guide sleeve in. Take our depth, which will be just about the same as the opposite screw, so you kind of have an idea for commonality. Get our correct screw length. We tap. Click and down. And you can see the screws are flush. Army Navy comes out. We check. We can get our final images. We get a lateral and an AP and maybe a Rosenberg equivalent, so we see the slope of the tibia. And you want that down the hinge pin hole, and it really looks nice. You can see it's flush here. Now we have a chance to put in our bone void filler right through this nice gap between tibial tubercle, patella tendon, and the device. And we have this big opening to put in our cancellous chips from our Remings, combined with our bone void filler of choice and maybe some BMA. So now with the closure, it's very simple because we went in carefully. We have this nice retinacular fold. The MCL is the deep layer. And remember, we released it so it's protected. It was pushed back for all the cuts, but now we're bringing it forward again. And once we free it up from being back there and rolled up during this case, we're going to bring it back down below the PEZ, which we have in our retractor here. And that's going to just go in flush. And then it goes under resting tension. So here's our superficial layer, our PEZ and our retinaculum. That's going to go up over, and we'll sew a Vicryl that connects those two, so they're each holding each other down in place under resting tension. A pulled out view shows that this now has a good valgus correction to this knee. Here's our hinge pin hole, and you can feel the cortex in this specimen. It's clearly intact, but you can confirm by fluoroscopy that hinge pin guide system really is the engineering marvel of this system.